So Shalom, welcome everyone to the second Montana-Israel Virtual Trade Forum, and this one has a focus on digital health. I'm Brigitte with the Montana World Trade Center, and our mission is to help grow Montana's international trade and investment portfolio. We have an excellent lineup of speakers for you today, and I'd like to thank all of them, of course. I'll introduce the first one in just a second, but I also need to thank our sponsors right now. We just couldn't do these events without them. Their perspectives make these events even more valuable for all of our participants. So thank you to, and I had to practice this to get the point in the right direction, to the Israeli Consulate, HealthIL, Montana High Tech Business Alliance, the Montana Hospital Association, Bird Foundation, Montana Bioscience Cluster Initiative, and Accelerate Montana, crafting workforce training solutions that scale with business. So we do these events in an effort to build trade. And while there are many opportunities for cloud computing trade between Montana and Israel, given our relative areas of expertise and the fact that we do still find ourselves in the midst of a pandemic, we thought we should drill down on one pain point where this discussion could have immediate impact. And that's how we landed on digital health, and more specifically, utilizing these tools to help improve patient outcomes. So now, to kick off this event formally and to underscore the importance that Montana places on building mutually beneficial trading relationships around the globe, we are very pleased to have with us today Governor Greg Gianforte. Governor?
Thank you, Brigitte, and it's good to be here to convene today's meeting. Just from the outset, I want to say Israel is one of our nation's closest allies, and I've had the great honor of traveling to Israel many times, including official visits during my time in Congress. I enjoyed meeting with Israeli governmental leadership, technology entrepreneurs, and spending time touring the country and seeing firsthand many locations of significant historical importance to all of us. Now, as governor, I'm looking forward to working together to strengthen our partnership as trade partners and friends, and appreciate your leadership, Brigitte. Israel, like Montana, has a proud legacy in entrepreneurship. Both Montana and Israel have many talented and big dreaming entrepreneurs. The collaboration between our federal government on national defense issues has been strong with Israel. I think there's more we can do in that area at the state level with Israel as our Department of Defense and aerospace vendors here in the state continue to expand. As Brigitte mentioned, Montana and Israel also have many cloud computing firms. The business I started with my wife over 20 years ago became one of the top 100 websites in the world in terms of traffic, and helped spark our high-tech sector here. And I know, see Christina's on the line, she'll share a little bit, but high-tech in Montana last year, according to the University of Montana, reached $2.9 billion in revenue and is growing 7 times faster than our overall state economy. So this is an area that we should be working more closely in. Pharma is another area where we should be working more closely with GSK and others putting research and manufacturing in Montana. There's work we could do between our pharma sectors. And still, for too long, Montana hasn't been living up to its full potential. And we're working to create more jobs and opportunities here and make Montana an even better place to do business and raise a family. Just in this last legislative session, we've cut our income taxes from 6.9% to 6.5%. We've eliminated the business equipment tax for many businesses with the Big Jobs Act. And I think of particular interest for our discussion here today, we changed our tax law to advantage entrepreneurs. We created the Montana Entrepreneur Magnet Act, which basically, if you start a business in Montana, operate it for a period of time, and it's your legit North American headquarters, the tax on the sale of the stock is taxed at 0%. This is going to be a real boon to attract entrepreneurs, and we'd love to have more Israeli entrepreneurs here in Montana. While we work to make Montana a better place to do business, we're also working to increase access to affordable, high-quality healthcare. And I think one of the silver linings from the pandemic has been that we've identified unnecessary and burdensome regulations specifically as it relates to telehealth, and that's the topic here today. Telehealth, particularly in a frontier state like Montana, is transforming how we care, how we deliver care. And I was proud to sign a bill into law this spring that permanently eliminated telehealth regulations waived during the pandemic. And if they weren't needed as we confront the pandemic, they're certainly not needed as we move forward. And we're committed to doing what we can to provide even more access to these services going forward. So as we meet today, I hope you're able to explore new ideas and perspectives and best practices on how we can use technology to expand access to care. Welcome the dialogue and look forward to sharing more productive meetings in the future. And with that, I will turn it back over to you, Brigitte.
Thank you so much, Governor. I appreciate you coming. So let me just give you an overview of the upcoming session. We're first going to go to a discussion about the Montana digital health landscape that is spearheaded by Sean Becker, and we'll have a couple panelists there that he'll introduce. We will have some brief Q&A right after that, using the chat functionality, please. And then we'll hear a little bit more about the digital health landscape that exists in Israel right now before going into some Q&A regarding that. And then we'll have a little bit of an opportunity for our Montana and Israeli groups to engage with each other before we finish up with a discussion from Maya with Bird Foundation, so we can discuss non-dilutive capital that can support research, development, and commercialization efforts for Montana and Israel firms working together. Okay. All right, Sean, over to you.
Morning, everybody. Great to be here. Sean Becker with the Montana Hospital Association. I have a great panel in front of you and a lot of exciting things to talk about. I want to first kind of give a quick overview of where we're at right now. I mean, looking at where the past 20 months have been fairly remarkable. And the role of digital health in rural areas is unquestionable. Per the CDC, people that live in rural areas in the United States are much more likely than urban residents to die prematurely of all 5 leading causes of death. And that's heart disease, cancer, unintentional injury, chronic respiratory disease, and stroke. All things that digital health could assist with. We know that access to care plays a significant role in this mortality formula, and are excited to see the introduction and adoption of impactful digital health tools. Thanks to the pandemic, the adoption of telehealth tools accelerated over the last 20 months. We would have never guessed 2 years ago that we would have seen such remarkable technologies, so the interoperability, as well as the adoption by patients. We have seen access to care, remote patient monitoring, improve patients' lives, quality of life, reduce readmissions, and improve patient outcomes. Per the headline of this event, patient outcomes has the Montana Hospital Association's attention, and it is something that we work hard on every day, as well as the panelists that we have in front of you. So we have some folks that are on the front lines of these issues and can shed some light on digital health issues and tools. We're talking with Chelsea Bonnar and Diana Linder about what technology is doing and is not doing, where they think we're headed or should be, any caveats or advice, and what the medical technology sector could be doing today to alleviate pain points in a rural state like Montana. Diana Linder is the Director of Grants and Sponsorship Programs at the Billings Clinic. Dr. Chelsea Bonnar is a pediatric physician and a digital health startup founder. So the goal of this event, at least from where I sit here today, is to build diplomatic relations with Israel. And we appreciate the partnership and the introduction, Governor. Thank you so much for being a part of this event. We want to share a little bit of market intelligence and get you thinking about the potential impact of telehealth solutions. Montana's healthcare industry is a proven innovator. For over a century, hospitals in Montana have developed and adopted solutions that improve patient care, quality, cost, and outcomes. We get it done, duct tape and super glue, one way or another. Montana's healthcare industry is truly a high-tech job creator and has the potential to influence how care is delivered in rural settings around the world. So without further ado, I would like our two speakers, Chelsea Bonnar and Diana Linder, to introduce themselves. Chelsea, could you start?
Sure, and I'm even unmuted. I feel like that's success for the beginning of our session. It's nice to meet all of you, and thanks for the chance to be here. I am a fifth generation Montanan. I say that with pride. I also say it with humility when I am with the communities who have been in Montana for hundreds of years and generations. And so I returned back to Montana after my medical training and working all over the country, working on pediatric access to care and health equity at a policy level and in federally qualified health centers. And now I'm the CEO of Montana Pediatrics, which is a Montana-based not-for-profit organization that works to build collaborative physician capacity to improve health equity for children in Montana. But my journey to this moment started almost 5 years ago, I guess, with being very enamored with digital health and telemedicine way before it was cool. And really looking at how is telehealth going to be more than just cloud-based doctors or a competitive option? How is it going to be more than an interest, quite frankly, in technology? Doctors can video conference too, was my belief. And all the things we're going to talk about today, regulations and how people work together and what the barriers are, were what I was interested in breaking down. And so that journey has led to, I founded and developed Telehealth Technology, a platform that was sold in September to a company that was interested in growing the unique capacities that we developed. And the premise there was the people who need to use the technology need to inform and shape the technology. And we don't always get that in healthcare. So that's a theme. And then the second piece was, how are we going to bring providers into this space that can feel scary? Feels like you're practicing medicine with your hands tied behind your back. And that doesn't sound so great until someone else can make it feel safe, make it feel comfortable, and can reinforce that it's high quality. So, thanks for having me. My other hat I wear is I am married to the president of the University of Montana. I am not an expert on everything that happens there, but we are always excited about the crossover between education, between workforce development, and between the exciting research that's happening in the university systems across the state. So thanks for having me, and we'll look forward to talking more.
Thanks, Chelsea. Diana.
Hi, everyone. Thanks for having me today. I'm here representing Billings Clinic. Billings Clinic is a not-for-profit healthcare system here in Montana. Our region is about 130,000 square miles, where we operate in Montana, northern Wyoming, and the western Dakotas. In that footprint area, there are about 650,000 residents and growing, hopefully. We've been doing this for about 100 years. That's about when Billings Clinic started. At this time, we have 550 physicians and advanced practice folks who are providing care across our region. We operate a hospital, a level 2 trauma hospital with 304 beds, and we also have a 44-bed acute care psychiatric hospital. One of the things we're most proud of is our affiliate network of 15 critical access hospitals across the region. And so we're working really hard to try to help provide care close to home for the people of Montana. Our geology really affects patient care in this region. And one of the things that we're very proud of is our Eastern Montana Telemedicine Network. This is a legacy system that hardwired accessibility to 44 sites. This was probably 30 years ago. And of course, times have changed, and we are in transition into a new digital age, and we're scrambling quickly to catch up with that and support rural critical access hospitals and patients living in our region. So we're very happy to be here today.
Thanks, Diana. 550 physicians, 15 critical access hospitals. I mean, all in all, Billings Clinic is delivering about a third of the healthcare in the state of Montana through the affiliate network. Is pretty significant. And a 30-year legacy of actually telehealth, starting right with the Burns Telecommunications Center. So telehealth to Montana hasn't necessarily been a new thing. Maybe could you tell us a little bit about some of the barriers that you have seen as this has evolved in Montana, and maybe where we are today, you think that maybe the most significant barriers are?
Sure, thanks so much for the question. So as I said, the Eastern Montana Telemedicine Network is a facility-to-facility hardwired system, but we're seeing now so many applications going directly into the home through the phone, the iPad, those kinds of things. And we suffer in Montana from a lack of high-speed broadband that is universally available. And so we still have some remote patients that can't get digital services directly into the home, that have to go into town to access that. We have, as you know, if you live in Montana, a lack of public transportation. And so vehicular trauma is a big problem, and supporting critical access hospitals when they have to face those kinds of situations requires us to provide specialists to support them. So those are a couple of the problems. Training physicians and other care providers to be ready to assume roles in rural and frontier communities is also a big theme here at Billings Clinic. As you know, Sean, we've started medical residencies and other kinds of services to help address that situation.
Thank you, Diana. And Chelsea, I mean, compared to the 30-year history of Billings Clinic, maybe a relative newcomer on the scene of just a decade of experience in this space, maybe more, as someone that's really seen great solutions fail and poor solutions get adopted, like maybe you could talk a little bit about that, the digital health divide and what you've seen work and not work.
Yeah, I mean, when you think about sort of the ecosystem of care, I think we get excited about thinking about telemedicine, but telemedicine is a less helpful paradigm than who needs care, what are the tools we need to do something high quality, and who needs to be involved to make that work. And how do we make sure there's enough regulatory components to that we feel safe, we feel supported, but that there isn't a hindrance to make that happen. And so it's no less human delivering telehealth than it is delivering effective healthcare to a family who's sitting in the room with you. Access issues are very similar, whereas we may need a safe road to drive on and a pass that has the snow cleared and a car that works and an office hours that work for us to see a patient. Those same concepts apply. We have to make that for patient access to telehealth. And so the places that have been motivating to us and where we've seen both, where you always have the sort of worry and the wonder about what could be better, we're sort of the early telehealth pushes at the national level. There was a lot of fascination by technology, as it should be, around what is our platform going to be able to do? And then you realize, oh, wait a minute, if I have a platform that delivers telehealth, I need doctors to deliver telehealth as well. This is going to be less interesting without physicians on the other end. And so some of the early models we saw valued technology over the actual humans who needed to be involved in delivering the technology, and sort of took a slot policy approach to the physicians. We'll just put some doctors on the one end of this and we'll call it healthcare. And I'm sure, everyone here could attest, and then the data attested very early to the fact that a doctor in a cloud on a computer who doesn't understand your context, doesn't understand your health history, doesn't have access to your information, doesn't understand what it means to go to the emergency room when you live in Wolf Point, Montana, and you have a 2-month-old, is not meaningful healthcare. So that was where our initial concerns at the national level in the pediatric world were, is are we calling something healthcare that isn't going to be meaningful? Fast forward to coming back to Montana and starting to really dive into the details of what is it going to take to bring greater access, meaningful access, and health equity, wielding the tools of technology. And we have found, again, it comes back to really deeply engaging with the communities that you're ready to serve, even though you may be remote. And so, we tell the story of arriving in a telehealth program that had been trying to get up and running with a great deal of funding over 4 years, and going out to see how this was going to work, and walking into the clinics that were intended to be delivering this care and finding giant, fantastic technology sitting in the box 4 years later. And so, and really like literally unboxing and plugging in and starting to work on that entire spectrum of, is there connectivity? Is there the device that we need? Is there a human on this end who understands the value of this? Are there patients who will trust the use of this modality? And are there trustworthy providers on the other end of this connection? And so I think this amazing moment in digital health is an opportunity for all of us to acknowledge where the technological solutions lie, but then also to really ask primarily patients and secondarily providers and systems, what are the tools that you actually need in order to deliver high quality care, and forget the fact that that happens to be remote, because fundamentally it's the problems are the same. So working in Montana, we hit many of the same barriers. What is the connectivity issues? Interestingly, I think when we look at socioeconomic status and we look at devices, something that was very important to us early on, the digital divide is not necessarily in whether people have a device. The digital divide is whether their device has reliable connectivity and whether they can afford their data plans. Those are places where I think we can think about intervening at a systemic level. So I'll stop, but that's where I would begin in this conversation.
It sounded like in your example that we're talking about digital tools, that community wasn't ready for the digital tools, or there wasn't the interoperability or the integration. It wasn't patient-centered, it wasn't provider-centered. I'm not sure who was centered on. Maybe where you're unwrapping boxes 4 years later. I mean, do you think that rural Montana is ready for digital health?
Absolutely. I mean, yeah, sorry, go ahead.
I was saying, Diana, I want to ask you the same question. So, but Chelsea, is rural Montana ready?
Yeah, but nobody is ready. No patients we don't walk into a patient's room and say, are you ready for MRIs? You ready? Like, is this something you're ready for? We walk into a patient's room and we say, we have a tool. We understand how it works. We trust it. We understand its utility, and we are going to facilitate your use of this tool to improve your health, because that is my job as your doctor. So I think the question of, is rural America ready for telehealth, is a question of, is the medical world ready to deliver, make trustworthy, and make of value this tool of healthcare delivery? And so, yes, I mean, absolutely. Every single patient that we see is extremely grateful for the access, but it's because we worked extremely hard to deliver care on their terms, and we've leapfrogged what many people have been able to do in sort of more path dependent or legacy systems. But I think the question of whether patients are ready for digital health is more a question of whether we as a set of providers are ready to do something of use, are ready to do something that is truly patient-centric, and we're ready to help patients solve the problems of seeking this care. Because I don't know anyone who would say, I would rather, well, I do know people who would rather not see their doctor on the computer, but they would, if they know that they can have something of value from their doctor. Rarely do people refuse the item of value. So I think it's a kind of a funny question, because I think it's really on us to deliver something of value, and then patients are grateful for that.
That's a very powerful point, to think about the use of digital tools as part of your medical professional opinion, as much as any other device or intervention. That a digital tool could help facilitate, outcomes, positive outcomes. Diana, speaking from the healthcare system and as an administrator, and maybe pivot that question a little bit. Not necessarily is rural Montana ready for healthcare, but is the medical world ready to deliver healthcare with digital tools?
Thanks, Sean. I think one of the things that we have seen in the last couple of years is the ability to use digital tools to support those rural providers that are out there in our rural hospitals. Through the Project Echo platform, for example, and that was developed at the University of New Mexico, we've been able to push urban expertise out to rural areas to support clinicians out on the front lines and expand their ability to take care of more complex patients. We've been using digital tools to help our critical access hospitals do a better job with their patients. More acute patients are able to stay in their community where they would like to stay and receive their care with digital backed support from urban medical centers. So absolutely, there is a huge role within the health system to support care in the rural areas.
And Diana and Chelsea, you guys have been working in this space for many years, really planning a thoughtful approach and how to integrate digital tools into a continuity of care and patient care across a number of settings. And then the pandemic happens. Is there anything that surprised you the last 20 months that you're like, I never thought that was going to happen, or or boy, that happened quick, or I can't believe that didn't happen?
Want me to go first, Chad?
World?
One of the things I think that we discovered very quickly is that there's a technical piece and there's an adaptive piece. And the technical piece is the sexier one and the one that maybe was easier to access. But the adaptive piece of training and preparing both sides and everyone in the system to accept the care, that's where we stumbled a bit, and we're still feeling our way through that, I think. Wouldn't you say so, Dr. Bonnar?
Absolutely. I mean, it's hard, as someone who developed technology, this may sound terribly sort of hypocritical, but the technology isn't the problem. Ask anyone who's been video conferencing for, the technology is the building blocks, the ability to video conference. Now, connectivity is an issue. But again, it's not the fundamental components of the ability to see, to hear, to talk to each other from great distances. It is all of the human components on top of that. So I think that adaptive component is enormously important. How do we create community? How do we develop standards of practice? How do we communicate with patients so that they feel that what just happened was of deep value? Whereas just walking into a clinician's office, you sort of assume the value in that interaction. I'm a terrible person to ask if I was surprised, because I have been a believer for so long and someone who's trying to bring people along in this process. So I don't think that I felt surprised. I felt excited that we had a little bit of a nudge in this direction, but we've seen a drop off again, right? It's not like telehealth came and stayed and this was the answer. Telehealth came and everyone endured. And then as soon as they could get back to doing things how they usually did, many people breathed a sigh of relief and hoped they wouldn't have to deal with that the rest of their career. So we do have in this moment an enormous challenge to understand, and I believe from the patient perspective, as well as from the clinical data perspective, what sort of gifts were we given in this forced moment of pushing medical innovation at a pace that it never moves, much faster, right? We got off the 20-year cycle for a couple of years. How do we then codify, understand, listen hard, and take the good things and make them sustained going forward?
My next question is about, all right, so we had these surprises, this idea, this acceleration through the pandemic, that getting out of the 20-year cycle. Are there some things that we learned over the last 20 months that maybe we should stop doing certain things, and other things that we expect will continue way beyond the pandemic or where we are, how we're having to operate today? And just for context, I mean, like Diana, Billings Clinic has been operating at over 150%. I mean, there was a headline at one point, it's like we're running out of hallway space. The workforce, it was very challenging, both with patients that have, with providers that have been exposed to COVID, that had COVID, or that the stress of the workplace was just too much. That, you know, incredibly challenging time where you're having to adopt tools at a rapid pace and new policies at a breakneck speed. And when things start to calm down, which they haven't, and I mean, maybe a little bit Billings Clinic, but you're still at capacity. Are there certain things we've learned, or certain tools that we either wish we had and we want going forward, or we have now and that we're definitely keep in play?
Yeah, that's a really good question. I think we made a lot of advancements very quickly. You're right. And one of the things that changed is sort of this ability to allow people to flex and work remotely or work in the office, you know, if they have a job that's conducive to that. Prior to COVID, we were very much an in the office, you know, culture. And now we have a lot of people that are working remotely or working from different places at different times. We've always done outreach here at Billings Clinic, where we send teams of doctors out to work in rural areas, or we do telemedicine from Billings out to rural areas. We're looking now at whether we can place physicians and other care team members in rural areas and do kind of reverse outreach back to the urban center with their capacity, which is really exciting. I think we've found that we still do a lot of face-to-face types of activities. You know, we just can't get away from those, but we're finding new ways to deliver services in the virtual environment because we've had to. And that's very exciting. I can't think of anything that we're doing now that we would abandon. I think one of our big challenges when you talk about capacity problems at our urban hospital is returning patients back to their nearest critical access hospital for rehabilitation in their home community. And we have some challenges with that, with in terms of patient transportation, and then supporting those critical access hospitals in that higher acuity of care, making sure that the patient has all of the inputs that they need and that they would have gotten, you know, in the urban environment. So that's something I think we're going to continue to work on going forward. We're really looking forward, though, to the time when we can get back to the new normal. When will that be, Sean?
2045.
Thank you.
I mean, with what's happened with the admissions, discharges, and transfers, how patients, the severity of the illness was so much more significant, how, you know, a length of stay quadrupled. I mean, just all of these compounding factors, you know, it's really changed like how it's in many respects, it's kind of our 9/11 moment for healthcare. Like the structure of airports has changed forever after 9/11. I think the structure of hospitals and then the scope of how we can deliver care will have changed forever as well.
I think
Kelsey?
so. We're really looking at wellness and resiliency among the workforce in ways that we have not before. We have a couple of research opportunities going on right now where we're actually collecting biometric data from employees and checking, you know, all kinds of health indicators to try to reduce employee stress. So it's a very exciting time, a very complex time, but exciting time for our healthcare providers.
You know, I wasn't expecting to go there, but you know, that's an incredibly important point, Diana, that on the provider side, that, I mean, this work has been very challenging. I mean, Montana has one of the highest suicide rates in the nation, if not the highest. And the healthcare community, the suicide rate is double the average. And so really substantially impacted by the stress of the workplace and by the pressure the pandemic has put on them inside and outside of the hospital. It sounds like the work that you're doing to work with them on wellness, on population health, on behavioral health. I mean, are there digital tools involved in that, or how have you kind of bridged ashore with those solutions?
You know, it's interesting. We're doing some things in the inpatient environment. For example, we've always had pastoral care. Everyone knows that pastoral care is a key resource for our patients. But our pastoral care staff has been rounding on our own employees as well as on patients. So we're doing a lot of work in that area. You know, the COVID pandemic, because of our restrictions on patient visitors and things like that, we've started using iPads to do virtual visits, you know, with family and things like that. That's pretty low tech, you know, but it's something that I think we'll probably continue to do into the future. We've started tranquility rooms, you know, where our providers can just go for a little while and take a break during the course of their shift. I'm trying to think of any specific technology tools that we might be using to help with stress. I can't think of anything. I know there are some emerging things like, you know, text messaging and chat bots and things like that for people, but I don't think we're using those quite yet. I don't know. Do you know of anything, Dr. Bonnar, that might be in this space?
I mean, the interesting thing about that is those tools would transcend professionals who are struggling or have these sort of senses of disconnection. One of the things that we have done that we've just, my examples are always sort of very small and on the edge, but, you know, I think to Sean's earlier question about what do we wish would endure or what do we wish we would have learned, and then also actually crosses over into this question about workforce and what did the pandemic either reveal about our fragility, or what did it aggravate, or what did it give us a sense of what the future could look like with a shrinking primary care workforce and an aging population in a rural state. It sort of aggravated or revealed trends that were otherwise true, I think. And so to sort of tie those things together, I have one example from, I think one of the things I hope we continue to believe is that it is time to redefine who are our friends and who are our foes in healthcare. And we, you know, some healthy competition is built into the American model of how we deliver healthcare, and it's codified there. But I think one of the things we learned is that in time of stress, our fellow healthcare professionals and systems are our best allies. And so I hope that we endure this perspective that we could be allying with providers and clinical expertise from Israel, right? Or we can be allying, or our foes are probably not the hospital system across town, because now if we are competing for market share, anyone can come into Montana, get a few licenses and compete. And as we accept digital health and we lift geography, we need to figure out how do we work together in new ways. And we have an example, we have a primary care provider who's the only specifically pediatric nurse trained, she's a nurse practitioner. It's really east of Billings, right? Who works full time. And she's on her own. And she's the only one who sees kids in her community. And so the complicated kids, the kids with medical complexity, that's on her shoulders all the time. And you can imagine the typical stress of that. And then you lay COVID on top of this. So this provider is a part of the Montana Pediatrics Network. And so she helps cover other people at night. And we've created community. And she called a few weeks ago and she was done. She was exhausted and she was going on vacation. And usually when this provider goes on vacation, her nurse calls her whenever one of her complex kids appears, because there's no one else who can take her place. But what we were able to do for her through the use of an innovative connection in technology, not only from patients to providers, but between disparate providers, was we covered her and she went to Hawaii and she didn't get a phone call all week. And that may seem small, but that is how we transform what it means to be isolated, to be practicing in a rural place, to be the only one in an adverse setting, and to still have clinical community that can help you get real relief. So I think it's one of the great questions of telehealth. I think one of the things I hope we hang on to is it's not just video conferencing between a doctor and a patient. It's a new way to think about our global healthcare community as connected and available to one another and to patients when needed.
Well, thank you both. Hopefully everybody enjoyed the conversation. This is a really rich discussion. At this point, Christina, are you, I'll turn it over to you or for.
Yeah, we have some questions submitted that we'd like to pose to our speakers. This one's for Chelsea. You pointed out some great things about the foundations. From a value perspective, do you see a particular patient population that has the biggest need or potential value? For example, chronic patients or acute patients or other categories?
So you'll find, I believe, there's value across the board, but certainly, I guess if it depends on how we want to define value. So if we wanted to look at where are we spending the most money and imposing on people's lives the most and providing the least effective care, certainly when we look at those with medical complexity, especially people who are dependents with medical complexity, whether those be young children or older adults who cannot get care on their own, that is a population I think we absolutely owe all of our effort to improve their lives and subsequently improve outcomes and cost. I will tell you there's one other lesson of this work, which is that when you make the fundamental shift that we come to you, you don't have to come to us, and you think about the opportunity to deliver healthcare, not on your terms, but on the terms of your patients, you discover populations that were easy to ignore because they were not showing up on your door. And so one example, here in Missoula, we have a home for adolescent moms and young women who are pregnant. And the physical location of this space is literally across the street from one of our largest hospitals in the state. But when we went and asked those young women, those young families, what does it mean for you to seek healthcare? They told us a story of lack of access. They told us a story of lack of trust, of needing to use an emergency room that was dismissive of them, high cost. And what we discovered was there was a pocket of a population across the street from the hospital for whom digital health, for whom being able to talk to us on their phone was a complete game changer. So certainly if we look from a market, where is the spend? Pediatrics, 3% of the population, 30% of the spend, the impact on these families, travel and lives, 50% of rural families who have a child with medical complexity have to quit. Someone has to quit their job just to care for that child. Like clearly we need to be there. But I think the exciting part about moving into the patient's space as where we deliver care is that there are populations who need us, who couldn't even come find us on our terms. And so there's a different type of value hiding there as well.
We also have a question, since we have some Israeli firms on the call, Diana, could you touch on the process through which Billings Clinic decides how, when, or which private sector groups it will work with in running patient trials for digital health solutions or other solutions?
Sure, thanks so much for the question. So we do have a strong orientation toward research and entrepreneurship at Billings Clinic. We run over 100 clinical trials in cancer, cystic fibrosis, MS, cardiology, and a number of areas. With regard to specifically to digital, we have a vetting process. Internally, we have what we call our CSI group, our Collaborative Science Initiative, and we have about 7 research scientists and data analysts and so forth that are actually in a service center here at Billings Clinic. And they employ a research roundtable approach. So once a month, new opportunities are pitched to the research roundtable that it includes clinicians, includes IT and funding folks like myself. My primary job is connecting funding to the people in the organization. And so I can tell you that the best collaborations, the ones that are most successful, have a physician champion. and are translational in nature. You know, we really are trying to speed innovations to the bedside or transform our health system in ways that maybe have been tested in an urban environment, but not in a rural environment. So those are going to be the ones that will be the most successful. I will add my email and phone address into the chat box so that you can use me as the first point of contact, and I'll get anyone connected with our CSI folks and our research roundtable.
Wonderful, thank you. We will have some more opportunity later in the webinar to have more Q&A. So we do have a few more questions that folks have posed, but in the interest of sticking to schedule, I'm going to introduce our Israeli panel, and then we can have another period of Q&A and maybe tie together potential connections between our two countries. I'm now pleased to introduce Shlomi Kofman. He began his term as Israel's Consul General to the Pacific Northwest in 2017. Prior to this appointment, he served as a policy advisor to the Deputy Foreign Ministers at the Ministry of Foreign Affairs headquarters in Jerusalem, Israel. Among other roles, he's had a 20-year diplomatic career, and we're so pleased to have him join us today. Shlomi?
Thank you, Christina, and good morning, everyone. In Montana, good morning, good evening in Jerusalem, and I'm really thrilled to be on this panel. First of all, my deep gratitude to all the partners. Brigitte, you're my partner in crime, so thank you for working together for the past, I would say, 4 years together on various events and meetings, etc. And your commitment is phenomenal. Thank you so much. Sean, Christina, Diane, thank you so much for taking the time and for being with us. It's really a pleasure for me to get to know you. And to our friends in Israel, to the companies, to Yoav Fisher from HealthIL, thank you for being a partner. Of course, Maya Vardi Shoshani, Bird Foundation, who actually not too far away from here, but who's also another partner that is helping us to connect together. Look, there is a very strong connection, a deep cooperation between Israel and the United States, and although we cover several states around us, I really have a special relationship and special connection with Montana. And despite the huge differences in our territory, we still feel closer to each other, and we find a lot of areas that we can cooperate with several events in the past, whether it was on water, whether in agriculture. And I think now this time we're focusing on health. I think it's natural, not just because of the pandemic, but because we have something to offer. We have common interests in promoting and bringing the technological evolution to our people, but at the same time, also the pandemic definitely helped us to focus more and brings us to share what our experiences and knowledge in the wake of current challenges in the past year, kind of challenges particularly. So and we are as I said, we have this strong relationship, strong commitment, and I'm really happy to see this forum, which I guess is happening, on Zoom because as a result of the pandemic, because it became very something which is common and acceptable. But I do hope that this forum and this discussion and what we hear from Montana, what we'll hear from Yoav, and from Maya will enable us to launch, another channel, another path of cooperation in the health industry, in digital health, just because it's so important to our people, and we need to focus on that, and we need to learn from each other what we can bring together, what we can share, our best practices and our challenges. So I want to thank you all for taking the time, for being here, for preparing the speeches, for preparing the presentation. Yoav, thank you for your commitment at, what is it, the evening in Israel? It's not a given.
Evening.
And you are the expert that brings the voice and the trends and the developments of the Israeli digital health community. And we're very happy to have you here. And later, of course, we'll hear from Maya Vardi Shoshani, Bird's Foundation, about what are the paths, what are the opportunities to cooperate together via the foundation to bring companies together. And that's our goal, is to help the people and bring the companies for the benefit of our two economies. So thank you so much, and the floor is yours.
Thank you so much. Allie, is it okay if I share a screen real quick?
Yes, go right ahead.
Super. I'm just going to show you what I'm seeing. Okay. So while I do this, first of all, I'm really happy to be here and join you guys. This is, I love these things. It's really interesting for me to meet new people. And welcome to Tel Aviv, here at my house right now. I want to give you a very brief, real quick, high-level perspective of what's going on in Israel, and then talk about, some paths forward, and all in 10 minutes. So first, what do? I work for an organization called HealthIL, which is very unique and different. HealthIL is actually a governmental entity. It's a nonprofit funded by the Israeli Ministry of Economy. It's not an accelerator, right? I don't do pitch nights and demo days. There's enough of those in Israel to do that. My work begins first and foremost with the organizations themselves, whether it's HMO, hospital, clinic, pharma company, whatever. And we do with them a very deep dive to assess and define their needs and challenges. And once you do that, you can kind of start to envision what a potential technological solution could look like. The other thing that's critical is understanding from them how they operate, meaning what does hospital X have to offer the startup on the other side? Is it access to data, access to KOLs, infrastructure, mainframes? Are there processes in place for absorbing external innovation, and so on? On the other end of the spectrum are all the startups in Israel, every one of them that moves at any stage. Our little internal CRM has over 1,000, doing all sorts of fascinating things. And over the course of the year, we try to match with a very deep and deliberate process based on this deep understanding of both sides. Because we're governmental, we work with all of our friends, Ministry of Health a lot, the Innovation Authority, and each one we work with from the same perspective. Let's look at the challenges of integrating technology from the perspective of the Ministry of Health and try to overcome them. We also work ecosystem-wide with all the investors, incubators, et cetera. So what's going on here, right? Israel has this, it's this recognized leader of the core tech drivers in healthcare, right? And core tech drivers, whether they be wearables, sensors, the whole term of AI, of machine learning, deep learning, analytics, et cetera. But there's also this proven culture of innovation that I'm sure a lot of people have spoken about. But more than that, there's also critical density of technical talent, right? There's a lot of turnover. All of the big tech firms employ a large amount of people here, every brand name that you know of, AWS, Google, NVIDIA, and there's a lot of interest. But uniquely in Israel, there's this infrastructure for the ideation of innovation, specifically in healthcare technology. And you can see here the amount of startups that are going up. It's quite a lot. So what's going on behind the scenes here, and I want to divide it out into a couple different things. What's going on with the government, healthcare themselves, industry, ecosystem, and capital. So from the governmental perspective, there's very unique things here that I have not really found in other places. Primarily that there's these very interesting national initiatives for healthcare innovation. Digital in Israel, for example, is this government initiative that focuses just on the data aspects and how to harness that data. The Innovation Authority is a non-dilutive equity stance from the government to support R&D, not just in healthcare in general, but they also support incubators. There's also tax abatement programs for R&D, all specifically for health. And there's also national projects, right? These three that I list out here are all projects to create data lakes, all based on different angles, whether it's genomic, whether it's this, that, whatever. the healthcare organizations themselves, and a lot of this relates to what HealthIL does, have gone through a very interesting transformation over the last 5 years. So first, this concept of innovation management, which is very nebulous and a lot of people touch. Sometimes it's practical, sometimes it's not, but we really try to create this formalized process and this method for absorbing external innovation. And now, over the last 3-4 years, even the smallest hospitals have at least someone who's dedicated to this process. The proximity of Israel and the interest of these healthcare organizations also really reduces the barriers to entry, right? It's really easy to access every hospital in Israel, and they're all interested in trying stuff out. And lastly, there's obviously the financial support for pilots that we talked about. Industry is also a key player here. All the corporates that pharma companies, device companies, they all have a presence here in one way or another. And they all see Israel as this local and potentially global innovation hub. And all of the tech players here are increasing their footprint in healthcare. These are just logos of people that I work with on the day-to-day, and it always increases just from the tech side of it. There's also a lot of money. Some would argue, and I tend to agree, that there may be even too much money, right? A lot of private capital goes into investing in startups in general, including in healthcare. You can see that Israel here has more VC investment per capita than the United States, almost double. It's quite startling. And high-tech investments are going through the roof. It's a whole other monologue we can get into. But also there's the ecosystem. There's a lot of support, accelerators, hubs, NGOs, all these people who give various services specifically for healthcare and healthcare innovation and technology of it. But, and this is where you come in, every startup in Israel wants to improve lives, right? Check, that's a given. But improving workflows and improving healthcare economics is a whole different scenario. And on top of that, you got to layer policy. Now, don't forget, Israel is a capitated national system, which is going to be radically different than the United States. And in addition to that, beyond just the economic model of it, the US is very complex, right? Israel is also complex, but the complexity of the United States, because of the sheer size of it and the difference between state and state, create additional layers of nuance, right? Even the difference in the remote care that we were talking about in Montana, there's going to be very different infrastructure and support in Billings as compared to like Whitewater. And yes, I Google mapped where Whitewater is as an example. So that's where you come in, and that's where I can hopefully also help. This understanding of, okay, where do things work? How do you operate? Whether it's in remote care, whether it's in pre-triage tools for chronic patients, whatever it is. And yes, the technology exists. I forget who mentioned that, but there's a very big gap between just building tech and applying tech in a way that makes sense economically and based on workflows and processes in Montana. So I'm going to end there, but my point is that hopefully these types of meetings can lead to more things future to foster those collaboration avenues.
Thanks, Yoav. Appreciate your comments. All right, so it's back to me to facilitate a little bit of Q&A in response to what you shared with us right there. I'm just reading through the chat here, so I think I'll just go with what I see first and we'll move along. So this is a question from Cynthia Bradford Lencioni at Montana Pulsara data, sorry. Okay, so data privacy is a hot topic around the globe in healthcare information technology. Many nations are undergoing transformation initiatives to modernize their healthcare infrastructure, including replacing archaic tools such as fax machines. Yes, we still have them. With new mobile technology. Would you please describe the current environment and potential market entry hurdles or barriers, as well as opportunities in Israel for U.S. companies to enter the market to offer innovative cloud-based SaaS technology to hospital and ambulance organizations? What can companies expect with regard to data privacy regs, vendor IT vetting requirements? Are cross-border healthcare data transfers permitted? That's a big question. Several questions there
It's a
in the
big
chat.
question.
Yeah.
But if I understood correctly, it's looking at it from the other perspective. It's looking from a US company coming to Israel.
Yes.
So my answer to that is that it really boils down to the infrastructure of it, right? You know, Israel, from a policy perspective, has things that are kind of leading, but from perspectives is also lagging, right? So the policy perspective of privacy is going to be critical to understand first. For example, Israel actually does not really have a data privacy policy yet, meaning the ownership of data is kind of open. They're working on it, but that's going to be the first thing. And the second thing to understand there is that there's going to be radical differences in the infrastructure behind the scenes, right? If you want to implement something in data privacy, then really need to understand the mainframes that the system in Israel lives on. Not to say that it's impossible, right? It's just a little bit different. So that's where I would start, is first of all, understanding the policy, and second of all, doing a deep dive into the infrastructure behind it.
Thanks. I am going to roll to her second question here before probably heading back to Sean, unless any other new questions pop up. So emergency management initiatives in the US and global regions are looking at ways to leverage mobile technology to break down silos, create shared consciousness in real time across public safety and healthcare organizations to improve response and recovery during mass casualty incidents and disasters. What can you tell us about where Israel is with developing systems of care and network communications that scale during emergencies? You can see the rest of that question.
Yeah, so that's actually a really good question. And I'm actually going to use the example of how Israel did a vaccinated rollout, because Israel is unique in this. Israel, again, as I said, centralized national healthcare system. And because of that fact, because it's actually geographically very small, and also because of the fact that the infrastructure is already digitized, Israel was able to very quickly create kind of a hub and spoke model for the first vaccine rollout. As you recall from the news, Israel is one of the first countries to have wide-scale vaccine rollout, and it really was, in a weird way, almost like, you know, this military kind of nationalistic push of this entire thing. It was unified via the Corona task force that happened here, and it was executed by the, from what I recall, by the medical corps of the Israeli army. And it was centralized, meaning there's one point of entry for all the vaccines to the one airport. They took one lab, which was across the street from the airport, in order to store everything. There was one service provider who did the logistics of transporting it out, and the 4 HMOs dealt with the kind of hub and spoke model of executing it on the ground. So that situation, when there's a crisis, Israel is very good at managing those scenarios. For better or worse, Israel has, you know, a long history of managing types of crises situations. And that was just implemented, that mentality, that process was implemented into the corona, into the vaccination push that happened, what, a year and a half ago now.
Yeah. We actually had another question pop up here, and this one is from Brent Kirkpatrick, and he's actually asking, can you comment on how ethics are prioritized in the HealthIL translational medicine approach? Are negative results translated? How are positive results translated? I don't know to what extent you might be able to comment on that.
I'm a little confused about that question. Brett, maybe if you want to clarify it for us in the chat.
Sure. We'll ask him to jump in there and do that.
Okay.
And in the meantime, Sean, I'm putting you on the spot there, but prior to our event today, we were talking about having the opportunity to have our Montana and Israeli panelists kind of engage just a tiny bit in this section. Is there something that you wanted to start with, Sean?
Sure. Hey, Yoav, nice to see you. I mean, Israel was recognized last year by Newsweek magazine as having one of the most advanced healthcare systems in the country. I think even one of the hospitals, Sheba Medical Center, was one of the top 10 in the world. You fully capitated system, socialized healthcare. What has that done really to advance technology, bridge the digital divide, helps service rural populations? What could you offer Montana and maybe being just one step ahead of us in terms of investment and structure on the emphasis on healthcare?
So, Sean, this is a really complex question, and you and I both know how complex it is to just find solutions into healthcare. Look, the funding aspect is easy, right? The Israel Innovation Authority is a national initiative to invest in R&D, not just in healthcare, but everywhere, right?
Right.
And, you know, it's my tax money that goes into it. And whether it succeeds or fails is kind of irrelevant, right? There was a national decision taken to fund technological development. So from that perspective, it's wonderful. And it's not to say that everything in Israel is perfect, right? The other big benefit here is that there is a good 30 years of digitized data across all aspects. That does not mean that it's necessarily accessible and or relevant, but at least there's a starting off point, right? At least there's digitized data to begin with that you can start working with and running algorithms on and doing whatever you want. So that's another really big infrastructure aspect that's kind of critical for leaping that forward. And the other thing is that, you know, because it's so small and because there's kind of this open door policy, it's really easy to get in front of the hospital themselves. Israel has become an amazing, because of all the factors that I talked about, this amazing alpha site for healthcare innovation, right? So in a weird way, it's easier now than it ever has been if you're a founder in Israel to do an alpha, whatever it is, or, you know, observational study, pilot, POC, you know, whatever you want to do, building an MVP here in Israel. That does not necessarily mean that this is viable outside of Israel. That's a whole different scenario. That's a whole different, you know, ball of wax that you have to deal with. But it is unique in Israel. I haven't seen other countries, you know, and I talk a lot to various organizations around the world. I haven't seen something like this anywhere else. That doesn't mean it's perfect by any means. There's a lot of work to do, both in bridging the gap, but also even here internally in Israel. But the core infrastructure for creating this ideation hub exists. It's something that I think Montana can also adopt, but it requires kind of like, you know, bigger people than just this room. It requires putting in money and state level funding and support programs and isolating what's good and what's bad. And how really do you help out, you know, not just Billings, but the entire rest of the country, the state, apologies.
We have some more questions that are popping up on the side. I would hop in and say, for what's a good time to talk to a product. Diana put her information on there. I'll put my information on the chat as well. You're welcome.
Yeah, I'll add mine as well, and we can all chat.
I'd be happy to facilitate those discussions with hospitals across the state and with my partners in all 50 states as well. There is someone in my role in every state in the United States. Coming back to the last question about, you know, being a fully capitated system, could you explain that? And then why digital health tools are so important in Israel because of the reimbursement structure?
So the reimbursement structure is radically different from what you live through, right? Mm-hmm. And it really is at the national level. If the government decides to include some, you know, remote diagnostics tool that is approved via CE mark FDA into the basket of reimbursed services, then it is immediately rolled out as an option to the country, right? That's going to be a major difference than what you guys see, right? I saw it a lot, especially right now. I think, Chelsea, you were mentioning about the drop-off in telehealth usage in the United States. But behind the scenes of that is also whether insurance is going to cover it or not. Like your scenario of this telehealth visit is good in this state for a person who's under Anthem, but for a person who's doing the exact same thing in North Dakota under United, it may not be covered, or if it is, it could be covered at a totally different rate. That complexity is effectively non-existent here. There's still the hurdles to get through to get approved, obviously, but once you're approved, it's a national approval.
And in the capitated model, is it capitated in the sense that any innovation that makes things more efficient is going to be of benefit to everyone in the system? Whereas the problem we run into here is some innovations are in the best interest of the patient and they are in the best interest of cost, but they're not in the best interest of the system that makes money off of the high cost, inefficient ER visits. And so we actually just run into internal tail chasing frequently, because improvement in cost means a decrease in revenue in the United States in all of our healthcare systems. And until we have a better model for supplementing that, we stifle patient innovation.
You're 100% correct. And there are tons of individual examples where that inefficiency is gone. For example, Israel does not have the whole concept of a PBM. There is no PBM. So that entire cycle of like the disturbance that a PBM creates in just drug delivery and drug allocation doesn't exist. So from that perspective, and I can cite a ton of tiny little examples where Israel, yes, is more efficient, right? Because it's a fully capitated system. You know, every year the Ministry of Health and the 4 HMOs who execute healthcare services go up to Jerusalem and argue about what is that capitated rate, but then it's set and that's it. And there's really no deviation from it. So it does create a lot of efficiencies from that perspective. Again, there are uniquely, Israeli challenges to integrating digital health tools and technological solutions, both also here in Israel, but there are very unique things, and Chelsea, you're 100% correct. There are unique things that a capitated model kind of, I want to say, releases the pressure of it, right? And like, I know that some peripheral hospital in the most southern corner of Israel has the same economic fundamentals as Sheba at the end of the day.
I think we've been given the hook to move on. Thank you, for letting us kind of jump in on your portion and ask a couple questions, and Chelsea and Diana for participating in this. Brigitte?
Thanks a lot, Sean, and thanks, Yoav. Actually, now we're going to move. Sorry, what was that?
I just said thank you.
Oh,
Happy to reach out with anybody.
You're welcome. Don't go anywhere, though.
Okay.
So now we're actually going to move into the part of our agenda where we have Maya Vardi Shoshani coming to talk with us. Maya is from Bird Foundation. She has been to Montana. We look forward to welcoming her back, but we really do appreciate partners like Maya and Shlomi and Ran and the folks at the consulate who take the time to come to Montana to learn firsthand about what's going on here, to get beyond the numbers, because Montana's statistics don't tell the entire story of innovation that's happening in our state. So Maya, please share a little bit of information about potential for Montana and Israeli firms to collaborate in research and development and commercialization type projects. Thank you.
Thank you for having me, and I'm sharing my screen. I wish I could be there in person and see your beautiful Montana, one of my favorite places. So I am, as Brigitte said, I'm the Director of Business Development for Bird, and I'm responsible for the West Coast and Montana. I'm based in California. And Bird is a very unique organization that is 50% owned by the US government and by the Israeli government. We are a binational industrial R&D fund. Although we are called a foundation, we are like a federally funded R&D program. We operate based on an endowment that we received from both governments. Both governments gave us $110 million to fund joint R&D projects between American and Israeli companies. And we do that by providing non-dilutive funding for the mutual benefit of both the US and Israel. On our board of governors, we have officials from both governments, with the chief scientist on the Israeli side and NIST on the US side. A big part of our work is the matchmaking. We facilitate introductions, and that is why visits to Montana and meeting Montana-based companies and universities and hospitals is so important. We are like matchmakers, and we try to help companies find a partner across the sea. And then if these partnerships or those matches turn into projects, then we can potentially fund them up to 50% of their combined project, up to $1 million, and in some exceptional proposals, up to $1.5 million. So we, as I said, we provide non-dilutive funding. We don't take equity or IP rights, and we can fund the project, the R&D phase, including initial stages of sales and marketing and patent registration. And if this is a conditional matching fund, the companies need to come up with a match. And if the project is successful and ends in commercialization, we get repayments. We are agnostic to sector. I spoke on Montana events about AgTech, and here you can see that we are also focused on other topics, but a large amount of our funding goes to life sciences and healthcare IT, digital health, of course. So I'm very interested in funding more projects. We have the money, we just need to find good projects coming from Montana, working with Israeli companies. And this is why I'm here and hope that we can make this work. We issue a general call for proposals twice a year. The next one coming up is in March. I also posted on the chat the link to that, and I'd be happy to connect with everyone, give more information about the process. It is a very simple process, not a lot of overhead. Starts with a short executive summary that is submitted based on our template. The most important thing is talk to us before submission. We review the papers. We can provide feedback on drafts. So talk to us if you need a partner, if you need assistance or want our help, we would be happy to do that. It is a competitive process. We have external professional reviewers from NIST and from the Israeli Innovation Authority. And they're looking for innovation for risky projects and for synergy between the companies, and of course for potential for commercialization. There is a big impact on the national level. So of course the funding is important, and we know that a lot of companies come for the funding, but also for the validation, the stamp of approval, and the fact that it helps in raising funds and it accelerates time to market. But on the national level, we see that it creates jobs. Israeli companies, they set up offices in the US, and we have an example in Montana of a bird project where the Israeli company actually moved their office to Montana. I think I'm out of time, so I'm not going to share some examples, but you can see that here on the screen. We have a pharma model, and I'd be happy to give all that information offline if someone's interested in answer any questions.
Thanks, Maya. And just to clarify for folks, just if they have an interest in something like this, you can help them find an Israeli partner, right? So they should be reaching out to you. Definitely, yes. Reach out to me, our website, birdf.com, and you can find my information there. Brigida would also may forward my email to everyone, and I'd be happy to share this presentation as well. Great. Thank you. And yes, just on the housekeeping front, we will be very happy to do connections on both sides for Israeli firms looking at Montana, for Montana firms looking to Israel post-event. So thanks a lot, Maya. I appreciate your time today. Well, we're coming almost to a close here. So I want to thank you all for participating. And then I would like to just kick it back over to Shlomi for our final wrap up. Go ahead, Shlomi.
Well, Brigitte, thank you so much. And Yoav and Maya, thank you for Yoav, thank you for being with us late in the evening. And Maya, thank you for your always phenomenal presentation and really telling the story of a connection between Israeli businesses and US businesses and potential to take it one step further. So thank you so much. Friends in Montana, thank you for being with us this morning. Thank you for preparing this event, which is, I hope, will open another door for another cooperation, for another channel of communication between us. And of course, thank you to the governor, to Greg Gianforte, for being such a staunch supporter of the state of Israel, of our mutual cooperation, of our ties, and what brings us together. And please, Brigitte, please pass my gratitude to the governor for the time he took to be with us and for his strong words that supports this event. Again, thank you all, and I hope that this will lead for more conversations.
More business. Thanks, everyone. Take care.
Thank you. Take care. Bye-bye.